Welcome to the Droma Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician. Welcome, Leah. Thank you so much for joining me tonight.
Thank you for having me. I'm very excited.
Yes, I've been waiting to do this a long time with you. So
yes, I know it's here.
I appreciate the flexibility, and I'm really excited to be here with you tonight, talking about one of my favorite topics, which is feeding and children. And we're going to focus more tonight on kids with issues. They could be minor or mild issues. They could be more serious issues. I'm going to list now some of the related podcasts. So if people say, why didn't you talk about lactation like nursing? Because you're a lactation consultant, done already. That talk is with Dr. Laura Macaluso, lactation consultant. I also interviewed speech therapist, Dr. Luisa Gonzalez. That one has a very similar title called Well Fed, whereas this is Fed Up.
Very cute though.
Again, thank you. More preventative and in the beginning. And also I interviewed Yafi Lavova. That was called Hunger Games. And that was really also on more preventative and for typical kids. So if people are interested in those subtopics, I think everything complements each other. We're going to try not to overlap. We're going to also focus on your specific lens, which is the occupational therapy lens. So I'm really glad you're here with me because as a pediatrician, I deal with feeding issues all the time.
I'm sure.
In full disclosure, I refer to you. So.
I'm happy to help.
Yeah, so I was so excited when I got your flyer. I immediately started handing it out.
I appreciate that.
It's an amazing resource because these are real issues. When I said minor, I felt kind of bad because if you're a child, nothing's minor.
Of course.
Yeah.
And it impacts the whole family too. It's not just that child. That kind of is why it's that hidden issue, it's meal times are important and they happen at least 3 times a day.
Exactly. So I want you to start with your occupational therapy / sensory lens. And it might be helpful to just start with talking about sensory integration and sensory issues because not everybody fully understands what those are.
Yes. And, as an occupational therapist, a lot of us kind of deal with a lot of questions about what is sensory processing? What is sensory integration? What does it mean if you have sensory issues? There's so many context words that often are overlapping and sometimes conflicting, and it can be confusing. So I kind of wanted to take a step back and talk about just what are our senses and how does the sensory system impact feeding and everything, and then kind of talk a little bit more about how sensory integration came about and how that impacts everyday life. So we all know, we have our 5 main senses. You have vision, how you're seeing; auditory, how you're hearing; gustatory, so what you're tasting; olfactory, what you're smelling; and tactile, so touch, right? But in the occupational therapy world and everyday world, we also have 2 other senses that not many people know of and greatly impact feeding. One is vestibular, which is how your body is processing movement, your balance, your equilibrium, and which takes place more in the inner ear. And that can happen just from how your head is moving when you're walking down the street, but also gravity constantly is impacting your vestibular system. So kind of think if you have some vestibular issues, right, you may as a child look maybe clumsy or having issues climbing up things, but also think about feeding. If you're having some vestibular issues, it might be really challenging for you to just sit in a chair and have that demand put on you and then ask to eat. So you kind of have to look at it through different lens. And then the last sense to make that 7 is proprioception, which is a little bit more confusing for people to understand. And that in a very basic definition is where your body is in space. I like to use that example of if you see a really tiny little narrow pathway that you need to get through, A, can I fit through? B, okay, how can I fit through it? Do I need to shimmy to the side? Do I need to duck down? So it's how your muscles and your joints are are taking in that feedback, so you know how to move your body through space. So those seven senses make up your sensory system. And it's how your body is taking in all of this information from our environment, bringing that back into our brain, and then communicating throughout our body. Um, and then that leads into this sensory integration world. Dr. Jean Ayres was an occupational therapist, and she is the queen of queens in terms of sensory integration. She truly developed the theory and the framework that guides us all to this day. She was an occupational therapist, she was a psychologist, and a neuroscientist. And she really established how there can be challenges in one or many of these seven sensory systems, and how any slight varying degree of issues in those greatly can impact development and just your ability to function in the day-to-day world. So if you look at how all those seven senses can impact feeding, right? Okay, you think taste and smell, okay, yeah. But there's so much more to that. I mean, you have to think of what the food is looking like to some children. It can be very overwhelming. Maybe it's way too hot, maybe it's too cold. So there's all these senses that you are taking in with your mealtime. And then in the sensory integration theory, looking at, okay, a child can either be hyper responsive, so they are overstimulated by this, or hypo responsive, meaning they're not responding enough. So maybe they need their food to be way hotter than you would ever think for them to get that sensation. Or maybe they like really spicy things because it gives them a little bit more of awareness of where that food is in their mouth. And then obviously there is a big gray spectrum in between those levels. So it's a complicated thing to discuss, a complicated thing for parents to understand and children to understand, but it's crucial.
That's an amazing explanation. And I'm going to say here that sensory integration, sensory processing is a broad topic. And we're
Yes,
going to
very
limit
broad.
it to just relating to feeding. And I'm going to have to go talk to another occupational therapist about other aspects.
I tried very hard to summarize that in a way, because I mean, it is a very complex topic that you 100% could have an episode of its own on.
Right. It really needs to be, because it affects obviously many more areas
Right.
than eating, but we're going to
Right.
stay focused on eating because
Yeah.
that's what you do.
Yes.
And that's a really important topic. So how does the sensory issues or sensory processing, how does that interweave with eating and feeding?
So, I mean, it can come about in so many different ways. I feel like often the sensory part of the feeding issues comes later, um, or in terms of like parents identifying it, more so because it's when children are establishing their own autonomy, and they're able to say no, and um, able to really you're really able to see with the child responding to that input. Whereas, if they're either breastfeeding or if they're bottle feeding, it's more concrete. It's not as complicated. So usually once either table foods are starting to get introduced, don't get me wrong, these issues can happen way earlier on, and usually they do start earlier on, but parents are seeing them, pediatricians are seeing them later on. It can present in a multitude of ways, and it's kind of that last resort. I often find parents coming to you saying like they're just eating their chicken nuggets and their mac and cheese, that's it, that's all they'll eat. It's stressful, and it's feeding becomes such a negative experience for everyone, and it's pressure filled, and it's not what feeding and mealtime should be.
Right, let's roll that back and talk about different types of feeding problems. Because I would say it's not just the classic picky eater who only eats beige food.
100%. Yes. um, I think it's important to kind of talk about where or why these feeding issues arise. Looking at it from more like the medical standpoint, right? That can start from a child being born premature and having feeding tubes, having everything kind of dependently happen to that baby in a very atypical setting, a loud NICU, and going into all of that. And just how those experiences early on, that 100% follows through development. I mean, think of all those neural connections that are happening at that point. And then looking at it from children who just have a complicated medical history, children with cardiac complications who've had multitude of surgeries, relying so much on a G tube or an NG tube or an OG tube, and how just that sensory input. I mean, think of that. You have a tube down your mouth and down your nose, in your stomach. It's bypassing everything that typically happens. And it also can cause some noxious stimuli, like a lot of reflux, just your gagging reflex, because you have something behind your mouth that you shouldn't have. So that obviously can lead into a lot of sensory issues with that. Children with genetic conditions, syndromes, I would say roughly, don't quote me exactly on this, but I think it's around 80% of children with any type of developmental issue does have some sort of feeding issue. And whether it's related to just, you think of a child with Down syndrome, right? They have generalized low tone, so they don't have as strong postural control. Okay, how does that impact feeding? Immensely.
Mhm.
So that's kind of like that medical bubble. And I'm summarizing this because you could go on and on and on. But then you also have children who just maybe had really negative experiences with their introduction to food. And it's not ever the parents to blame on this or the medical providers to blame on this. Sometimes it's just a lack of awareness, a lack of education. So when we're coming in and doing this assessment, okay, like let's take it back. Let's get everyone on the same page and let's get everyone comfortable and educated, to try to change that mealtime and change that approach for the child so that it's not a negative experience for them. We also have least in summaries, children who were exposed to opioid use can have a major impact on feeding later on in the world. Also, any just structural or physiological issues that they were just born with and maybe go undiagnosed until later on, meaning maybe there was a slight case of laryngomalacia, or maybe as a baby they had laryngomalacia and then it's resolved. But we missed kind of what happened as the child was learning how to eat, and now it's more evident and showing up later in life.
Right. And laryngomalacia is kind of a floppy airway that I did
Yes.
discuss with Dr. Geller, who's an ENT.
Yes, that we're all related.
It is all related. And I'm hearing some themes of different reasons why a child might have feeding issues, one of which is coming through, which is aversive experiences.
100%.
Right. So that could be a preemie who's literally had tubes in their throat, with other medical conditions, but it could also be a child who's pushed.
Yes.
Right? So I want you to go a little bit more for the typical child, or how they would have aversive experiences, and maybe a little bit to avoid those, even though I did discuss them in the other time.
And like I always say, I always approach feeding issues, and especially when kind of those cases where I can say and see quite clearly that this child is on defense mode, right? Whether their underlying sensory issues are because just of negative experiences or a combination, and that they do just have sensory issues at start, we have to establish trust for that child. So if early on you're being told as a parent, and you have no basis of anything really on what to, and you're just trusting what you're reading, what you're seeing on social media, there's such a pressure. Do this at this age, do it this way. And parents often hold on to that. So, if they're introducing, say if they're bottle feeding, right? Baby's done great with the bottle, always done great. But now it's time to introduce a straw cup, and thinking that it just happens right there. And this isn't even introducing food, but just another form of fluid intake. And they're constantly just berating that child and just, no, you got to eat. No, you got to eat. Squeezing that water or milk or whatever into their mouth. I always use the example, like, picture you running a marathon and someone's holding a water bottle in your mouth saying, drink it. Like, no, I'm telling you no. But parents sometimes don't understand what those cues are if their baby's not talking yet, to say no. And they're those stress cues or those stop, no thank you cues, but they just keep pressing. And babies are smart, children are smart, and they're resilient. And so they take that, and their brain is taking all these different synapses at that time saying, nope, feeding, no thank you. Straw cup, no thank you. A spoon in my mouth, no thank you. So as that pattern is established early on, it follows them. And that's when the child holds on to the stress and it does become aversive. And in the NICU, I always would tell my parents, this matters, like right now matters. Yes, they are a tiny baby, but these synapses are happening. Their brain is making those connections now. And your approach to introducing food now and when they're 6 months old, when they're 8 months old, it matters.
Right. That's a really good explanation. I'm also thinking that a common scenario is a child who the pediatrician may say, not gaining enough weight.
Oh, yes.
I don't know
The
if you want
number game, as I call it.
like these are the patients I send to you.
Yes. And I appreciate that because so often parents are told, and I understand 100%, weight is important. Like you need to gain weight to develop and your brain, like you need that. But sometimes parents hear that and it becomes what I always call the number game,
Right.
right? They lost X amount of weight. We need to have them gain this amount of weight in 1 month. Like, whoa, pressure's on, let's go. So the intentions are always true for the parents, but how does that reflect on the child? And again, this is a typical developing child who we're just talking about how this exposure and the introduction to feeding is automatically pressure filled and automatically stress filled. So if you look at that with a child who does have some sort of developmental disability and or complicated medical history, and now you're braiding them with that pressure and the stress on top of a parent who also has trauma to themselves because of just the fear of their child having a complicated history, and wanting their child to grow and do the best they can, it can get messy.
Right. And I think also I'm hoping that physicians, pediatricians listening to this understand that it's so emotional. There's nothing more private,
So emotional.
right? Nothing.
Yeah, I mean, I find like
Mhm.
majority of my sessions, especially that initial session, it's almost like a one-to-one therapy with the parent, and that has to happen,
Mhm.
because they need to trust me, the therapist, wherever, so that they can trust their decisions they're going to make with feeding and mealtime, waking and meal pressure. Like that's a bit very heavy topic for parents. There's a lot of guilt that comes with it. So you have to be very sensitive about how you're approaching that with parents. And I always respect pediatricians so much when they're saying, look, something's off. It's okay. We're going to help you by giving you and your child these resources, right? It's not just go have your child eat more food because it's not that simple. And of course, the parent wants them to just eat that food or drink that bottle, whatever the issue is. So typical children and then children with who need more support, it's a heavy topic. So I think having pediatricians on board with that and understanding exactly what you said, that emotional component is so huge.
It's really huge. And we really need to think carefully how we talk to parents.
Yes.
Right. And I feel like there's more than one category. And again, this is not
Mhm.
medical advice. Speak to your pediatrician. Um,
Yes.
Keep a nice. But,
Just the biggest thing is we have to be a team.
right.
We have to be a team for the parent. We have to be a team for the child.
Right. So what I was going to say is that some children are just genetically small.
Yep.
Sometimes they're born to genetically small parents, and sometimes the genetic die have been rolled. And I was a small child. I was
Yeah.
parents. My parents would bring me shakes at night. I want them to take them back.
Yeah. Yes, and you remember it.
I do. And I remember the anxiety about it.
Anxiety is a big word, yeah.
And then you convey that to the child. So I think it's important. You really need a team to say, is this child getting enough calories? Are they growing the way they should be? Is there some medical condition? And it's not a one size fits all, literally. Approach.
Yeah. And I see that too with babies who are having a hard time, whether they're exclusively nursing or a combination or formula fed, where they hit a plateau, usually around that 4 month mark, where for whatever reason they're not meeting the next step. And pediatricians or parents are just hearing, talking to other family members, wherever they're getting this information, start solids now. And then it's like gears switch. Okay, let's do this. Spoons are out, plates are here. We're starting this. And I think it's so important to look at the child and say, do we need to be starting this at 4 months old, like we should be waiting until around 6 months old. And the reason for that is postural control, development of senses, development of awareness, their ability to bring their hand to their mouth, giving the child that independence to be a part of feeding and be a part of establishing routines. Now, I think it's super important, before that 6 month mark to expose the child, have them sit at the high chair during mealtime. What does mealtime look like? Play with the mashed potatoes on their hands. It's the goal isn't eating, and the goal isn't those calories to come in, because they're getting that through their formula or their breast milk at that point. But I think you have to be very careful of how you word that to parents, because they can take it and just run and get that weight in through feeding, but that's not going to happen that way.
Right. And it's interesting because the speech therapist I interviewed, Dr. Gonzalez, said that really she thinks 4 months is the right age. And you're saying 6 months?
I think 4 months for that exposure, like I was saying, but it has to be child led, where let them put the
Right.
avocado and mash it on their hands. Let them be a part of mealtime. 100%. I agree with her on that. But I think it becomes tricky when parents are taking that and saying, let's just spoon feed you with everything and not having the basis. Maybe their child's not ready. Some children might be, but if you don't have adequate head and neck control, and you don't have adequate postural control, and you're having this baby flop around in a high chair, and you're shoving a spoon in their mouth, what is that happening oral motor wise? And is that creating a negative experience? Are they gagging? I often hear that gagging word. My child's gagging on everything. Okay, they shouldn't be. And let's try to figure out why, right?
You know what, though, I want to stop for just a second, because one thing
Yeah.
that Dr. Gonzalez said was that you need to get that window between 4 and 6 months to prevent them. They need to desensitize their own gag reflex.
Yes,
They do it themselves. You give them a spoon.
exactly.
Right.
Exactly. And it's very, think about when you go back to the sensory aspect of that, if you're giving them applesauce and it's freezing out of the fridge, when has that child really ever had exposure to something that cold in their mouth? Probably not often. So let them take that time to explore it, feel it with their hands, mash it around, play with it in their tongue, in their tongue, be able to understand that you need to push that food backwards, versus just that typical, which is all part of that normal oral motor development, pushing it forward, but allowing the child to do that at their own pace and understanding that's normal and it's okay. And you don't need to be constantly berating them with the spoon saying, okay, eat this next bite, next bite. Just let them explore it for those first couple of months, because Louise is exactly right. That's how they learn, and that's how that gag reflex desensitizes.
Right. I'm wondering what you think about baby-led weaning. I didn't warn you about this question. This is a fun
yes,
thing.
no, and I was prepared to answer.
Good.
I think it's wonderful if the parent is on board. I think it can cause a lot of anxiety for a parent, but it can also create a lot of freedom for the parent and for the child. So if I know it can be very nerve wracking. You're like, God, my baby's going to choke. And if you're constantly in their face giving that heightened anxiety, right, that's meal times for their baby. Versus if you're under the impression of we're just going to let them explore and have it, baby led, it's wonderful. But you can also do baby led with purees, which I think is a big misconception and I think is so important. Baby led has a very specific approach, but you can take that and do what you want with it. I did a combination with my first child, my second child. It was just easier to just go right in and it worked. But I don't think it would have worked for me with my first child, even as a feeding therapist. So you have to look at the parent, you have to look at their lifestyle and what they're comfortable with and educate. And know that you can do it with purees. Load that spoon up, give that spoon to that baby, put it on their high chair tray, let them explore. Be okay with that fully loaded spoon not being swallowed and taken in as calories, but be okay with it just as an exploratory experience for the baby.
Right. And I think, though, that as they're more ready to be fed, I think that feeding them, not just the baby-led weaning where they're expected to get all their sustenance themselves in its more extreme form, I think it's also helpful to feed the baby.
Yes. And it can be easier in terms of cleanup and just the day-to-day aspect of it 100%. And you can do whatever feels right to you. It can be a combination of it all. Baby led, I do get nervous sometimes when people aren't doing the proper education with food sizes and food presentation. But also you have to be comfortable with it, and you have to do your research as a parent to do that.
Can we talk a little bit about the concept of the window of feeding, the window of learning feeding skills? Because I alluded to it earlier when I said that Dr. Gonzalez said, don't wait to 6 months. It's too long.
Yeah, and I find out sometimes people, I'm getting these consults in and they're like, oh, they didn't start really exploring or eating food till 8 months. So much happens before that. Everything, we talked a little bit about your sensory experience, how you're constantly taking in information from the environment. I mean, that is happening all of the time for these babies. They're picking up a teething ring, they're picking up a toy, they're putting it in their mouth. That's telling the baby and teaching the baby how to move their tongue, all in prep for feeding. So if you're missing that window, that like kind of sweet spot between 4 to 6 months of just exploration and understanding how your tongue is moving, how to push the bolus back and manipulate a bolus of food in your mouth, it gets lost in the shuffle. And so then the child doesn't have the foundational skills as to how to manipulate food, how to chew. So then it's either falling out of their mouth, and then parents are getting nervous. Oh, no, 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 eat, eat, eat. And again, you're getting those negative experiences associated with feeding because the parent's doing and kind of shoving and not allowing the child to learn as they should.
Right. Have you seen more children with feeding issues? I mean, we're talking about basically typical kids
Yes.
with COVID.
Sorry, with COVID is
No, since COVID, since the pandemic, are you seeing more otherwise typical children with this kind of problem? And I mean, like feeding in that they were held
I
back.
would say maybe not more, but I think there's more attention to it because I think parents either were home for longer periods of time, and especially with their babies, they weren't going back into whether they're working from home or whatever, where they're just more aware and asking more questions about it, and maybe putting a little bit more stress on it. But I wouldn't say a huge increase since COVID. I do find that people are wanting to nurse more than I was around earlier. Maybe it's just like the happens to be a fluke, but I think maybe because people had more time. And that is always best. And I think parents who do have children who are nursing their babies, that is allowing the baby to have some of that more freedom. So the parent sometimes is able to look at feeding through less of a force lens, if you want to call that, or a pressure lens, versus them always doing the feeding with a bottle and kind of going through that way. But I wouldn't say necessarily a huge increase in feeding issues after COVID.
Mhm. I was seeing them, but maybe it was just, a coincidence.
Yeah, I don't know. I'll have to pay attention a little bit more to it.
Yeah. So also, I don't know if you see kids who they don't transition to solids. And so the parents are worried that they're not getting enough calories. So instead they give them the bottle or the breast or both.
More often.
Mhm.
Yes, that is a huge issue. One of the biggest things that I start with is like, just walk me through what's your schedule, not just feeding. I want to know what your play is, what your child's sleep is, what your family meal times look like. Do you guys also, all of that is so important to understanding the family dyad with meal times. And like I was saying earlier, that kind of guilt as a parent you want your baby to eat. So if a baby's just not taking into solids as maybe their older brother was, or their friend's child is, or what they expected it to be, they're like, oh, well, they didn't eat a lot at lunch, so let's just now give them another 6 ounces. And then it comes to dinner, and there's no ability for the baby to feel that hunger and establish what hunger feels like. And that is a huge part of mealtime and feeding, and having the autonomy to say, I'm hungry, whether you're crying, reaching, pointing, gesturing, asking. That's a big part of it. And if I understand as a parent why you're doing that, of course, but that is the big piece. And there's a lot of nerves around that when I'm like, take away that afternoon bottle, or take away, you don't need to offer that snack. There's some grazing involved, and it's that heightens the anxiety, and that gets parents very fearful that they're not going to take in the calories. And I think a big part of that is also understanding, I don't expect your 6-month-old to get fulfilled 3 meals a day. No, they're not. That's not where that fulfillment's coming from. And understanding that as a parent and saying, okay, they're still getting most of their nutrients, majority of their nutrients from either breast milk or formula. But this is how we're introducing for the next step of feeding. And when they're at that 12-month mark, and maybe they're still not just eating a lot, let's look at what we're doing in terms of how often we're nursing or offering a bottle.
Right. I like to, at the 9-month visit, say how much milk is your child taking and try to give them
Yeah.
a goal so that by the time they're 12 months and they're going to transition to cow's milk, that they're not on more than 24 ounces.
Yes.
Some of them are 30
And I
to
think
40. They're not going to have room to eat, but also I don't want them to
exactly.
32 to 40 ounces of cow's milk.
Yes, and I often will get, I give them their bottle, and then right after their bottle, they have lunch, and then all of a sudden they're throwing up or they're spitting up, or the other side of it, they just want nothing to do with it. And you have to kind of change the parents' lens and their view of thinking and say, okay, like, would you want to eat after drinking that much milk? Probably not. Um, so again, if you look back to a child who does have a developmental disability and or underlying sensory issue, and you're just presenting this normal feeding experience to them and overwhelming them with food, what that can do, and how that can impact feeding to the next steps, which is kind of how sometimes we see those feeding issues arise because they're almost like stuffed, right? And then feeding becomes negative because it's that forced high anxiety mealtime.
Right. Let's talk a little bit more about the children who have
Mhm.
sensory issues or other special needs. Some of the
Um,
issues that they're
So a
facing.
big, obviously, topic is children on the autism spectrum disorder and where they fall in that, whether they're very involved under, like, what they're where under the umbrella they are. I would say a very large amount of those children do have feeding issues, and feeding issues also sensory issues, right? If I very rarely come across a child, I don't think I ever have actually, who has just a sensory issue with mealtime. Um, no, that's not how our body works. It's usually I'll talk to the parents on the interview, and they're having tactile defensiveness with toothbrushing. They don't like the way their socks are feeling. They don't like their jacket on. And okay, that's how the body's taking in and interpreting all those signals that we're getting. So how do we set this child up for success, and how can we adjust and help the child and the family?
Right. So, what kinds of things do you do to help these kids?
A lot. It depends on the child, of course. I think if you're talking just like cookie cutter picky eaters, I find the biggest thing is how can we just set up that child for success at mealtime? And a lot of that is just reducing the stress and giving the child the autonomy. But at the same time, setting the child up for success. Do they need, and educating the parent on what that child would need before mealtime? Do we need to set up their chair and their table so that they have a little bit more postural support so they're feeling more grounded so that their proprioception improves? So then they can participate in mealtime a little bit better. Um, can we give them a different type of fork or spoon so that they're having a little bit more comfort in terms of holding? So there's so many things that we can do with the external environment, but also so many things that we can do to the child. Sometimes it just takes needing to that child who's a little bit under responsive, giving their body, their whole body, input before mealtime so then they're more organized and able to better manipulate food and experience food and respond to food. We're on the other side of it. I'm kind of going one end to the other in terms of under and over responsiveness. Do we need to just reduce the stimulation during mealtime? Is it too much? Is the TV blaring? Is there music playing? Are the lights all on? Is there clutter all over the table? So how can we reduce some of that stimulation for the child externally so that internally they can then, process and encourage mealtime to be positive?
Right. And I want to add that for children with significant feeding problems, there is
Mhm.
feeding therapy, which is really
Yes.
through a speech therapist trained therapist, correct?
Yes and no. There are so many different approaches to feeding therapy. I'll kind of summarize a lot. There's like the behavioral approach, which I don't always love, or because looking at it like as a behavior, it's not, there's always a reason for a behavior, and we can't just treat the behavior. We have to look behind that.
Mhm.
Some people have had great responsiveness with those more structured behavioral approach programs. I find they're short term, that success. And then there's also more of an integrative approach where it's, child led. So we are taking all the pressure off, and we are just meeting the child where they are. And there needs to be consistency with that. It can't be just a breakfast. It has to be consistent. That's how we establish trust with anything. And understanding that, okay, I'm going to put your preferred food on the table, but I'm also going to put maybe a non-preferred food. And it's okay if you don't eat it. As a parent, it's okay that you don't eat it. The goal is just to have it be there and have the child be okay with it there. And it's a slow process. So kind of combining all those sensory treatment approaches that you can do before and after mealtime, on top of what mealtime will look like, adjusting the environment. There's intensive programs where your child goes to an outpatient program. Again, I find those programs aren't as successful because it's not in their natural habitat, right?
Mhm.
So there's small success, like, okay, you took a lick of peanut butter, or whatever they're doing, but how does that translate long term? And again, every child's different. One child might respond better than the next, but it is so important to get that interview from the parent, spend time with that child to really figure out what are they responding to, what do they respond well to, and how can we transfer that into feeding and mealtime.
Right. I'm wondering if your perspective as an occupational therapist would be able to work together with a speech therapist who's expertise in feeding, because they're
Oh,
different.
100%. I mean, I think that's also one of my first interview questions is, who are you currently working with? And it's not just therapy. I want to know GI. I want to know your dietitian. I want to know your birth history. Like, I want it all, because it all matters. And parents so often carry that guilt and confusion because they're having such conflicting information. GI saying, "Oh, they're having reflux. Let's thicken their milk, and that's going to fix it." Okay, but then they're having more GI issues because they're backed up, and it's exactly so. There's so many moving parts, and I think as a medical team, you have to work together. I have to be able to call you and say, "Hey, I can't figure this out. What are you telling the parent, or how can we figure out to get the child more calories? Let's pull in the dietitian too." And that helps the parent establish trust within us too, because they don't feel like they have to bounce back and forth and wait for this call and that call. Um, so I always ask permission. Are you okay if I reach out to your specialist? Because we have to work together.
Right. That's the way it should be.
Yeah, I
It's,
know it's not always as easy, um, but it should be that. And
yeah.
there's we miss things. And a speech pathologist, if I'm ever concerned in terms of,
Mhm.
okay, there's something more going on than just a sensory issue, like they're not just gagging,
Right.
they're sounding really wet after mealtime. And I ask parents, what is that typical? Is that lingering coughing happening during, after, or is this just this food texture, this food consistency? Sometimes kids are fine on purees, and then once they move to a more solid based form of food and they don't have the capacity to safely swallow, that needs to be addressed. And that's when I say I'll refer out to, if they're not seeing a speech language pathologist at that time, to either do any more medical testing and or just collaborate with them to make sure that the child's safe.
Right. And you may need to see an ENT slash
100%.
see
Yes,
if there's any kind of reflux, any kind of airway problems.
exactly.
Everybody has their part and you got to pull it
Oh,
together.
100%. Especially too, if you're looking at a child who maybe they're 6, 7 years old and they had a surgery when they were a baby. They had a feeding tube for a while. They had a breathing tube for a while. What did that do structurally? Did that ever get investigated? Maybe, you never know. So it may look on the outside as a sensory issue, and it probably is a sensory issue, but like, let's get to the bottom of it. Is it something structural? Is it something developmental? Or is it just purely sensory?
Right. And you should be able to talk to your pediatrician. The pediatrician is supposed
Yes.
to be the orchestra leader here,
Yes.
but we're busy. So
Yes.
it's hard
Yes.
to fill
A
the
hundred
time.
percent.
Best advocate trying to pull everything together.
Yeah. And I think as a therapist, empowering the parent to ask more questions and be their child's advocate. I think often parents with children with disabilities often feel like they always have to just be told what to do when they sometimes know best from another lens, of course, but maybe the best approach with their child. So if they're going to whatever doctor or whoever specialist is saying, pack the calories, let's get this child to gain weight, why isn't the child gaining weight? So we have to understand that the parent might have some valid information as to behind that, and trusting the parent to ask the pediatrician, ask the specialist, and get everyone on board to work together.
Right. That's really important. I want to go back a little bit to gagging,
Yes.
because I think that gagging is a normal stage
Hmm.
to a point,
Yep.
but it's also scary. So I'm just
Yes.
wondering what you do in this area.
Yeah. So educate, educate, and provide comfort and confidence. I often take my first one or two sessions to just sit back and observe. I can't go in there and just tell what to do because that's not helpful for anyone. And I think you have to observe how the parent's reacting. If you think about it from how much sensory information you're getting as a baby or a child, if you're gagging and your mom's like, "Oh my God, now are you gonna," and then gets all nervous and excited and sees fear, right? Again, that sensory information that you're taking in, it's only gonna further that reaction. And instead, I always try to say, it's okay, it's normal. You're going to see gagging to a certain extent, right? You shouldn't be gagging at 8 years old, but in that terms of that normal exposure to food and initial feeling, that's the child desensitizing that gag reflex and understanding how to manage it. And it's okay and it's normal. And you can just redirect or just ignore and continue on.
Right. Do you ever see kids who don't transition to solids?
I do, but those kiddos mainly are my more involved children with like medically complex issues. There's a whole realm children who have been on feeding tubes for a very long time and have never been given. So there's the medical complexity, right? Where they're just maybe not able to, because it's just not safe for them, right? We talked about having modified barium swallows, ENT involved, doing all these scopes just to make sure. But then there's also the child that has had all these tests done. Everything's normal, but they're just not able to progress with eating solids. And I think a lot of the time is they just don't either know how, and it's because they never have been given the opportunity to learn because they've had a feeding tube for so long. Um, and they've never felt hunger, right? They're getting overnight feeds. That's a big one, where their G tube running or is overnight. So they're eating while they're sleeping all night long. So no wonder why they're not really excited about eating the next day. So that is one area where I do see that they're just not eating solids. And that's a big team approach where there's specific programs too that I would definitely outsource and guide parents to, where it's hunger based. Let's get your child to understand what hunger is. And then while we're teaching them what hunger feels like and that sensation of hunger, okay, now what does food in your mouth feel like? And desensitizing all of that taste, smell, texture, touch, all of that while understanding what hunger is. And you're teaching the child how to do that at a much later age.
Right. I mean, I've definitely seen children who do not have severe, not preemies, not tube
Mhm.
fed, who do not transition well, or whose diet is primarily ends up being
The
something like.
shakes and the, yeah. And I typically find a lot of that is they had a sensory aversion for whatever reason. Parents got very nervous about weight gain, so just push the shakes and the liquids and the milk and all whatever they're able to do to get the calories in. And it diminishes, like I was saying, just the autonomy of hunger and that the autonomy of the child to participate in mealtime. It's such a passive approach. And again, it's not the parent's fault. You have
Right.
to meet them where they're at and have them trust you that no, we can take a couple of these shakes away and we may see it. And that's where I think it's so important talking to the pediatrician. Like, we might see a little bit of weight loss for a period of time. What are you okay with?
Right.
Is this okay? But we have to be able to find that balance and have the child learn to trust mealtime and teach them how to safely participate in mealtime.
Right. Is your kind of therapy available to children who are in early intervention programs or preschool special ed or special ed? Or is it just private?
Me specifically, or
I mean, your kind of therapy. I know you're a
um,
therapist.
yeah, I mean, occupational therapy is 100% involved in early intervention. Unfortunately, I think the funding, um, you're not guaranteed always to get a skilled therapist in feeding. So you might get an occupational therapist or you might get a speech pathologist, but maybe they're not skilled in feeding. And unfortunately, I mean, you need to be skilled in this. There are so many variables that participate in feeding and the safety of feeding. So, like I said, it's not just sensory. It's not just swallowing like a dysphagia. Like, there's so many things involved in it. And yes, it's covered in early intervention, but you might not get that skilled therapist. Does that make sense?
Right. And you can ask though. You can say, this is what
A
my
100%. And that's, again, I'm always like, be that squeaky wheel. If you're not happy with your therapist, and they may be a fabulous therapist. I have expertise in areas, but I also don't have expert. And you want to make sure that you're giving your child the best foot forward to go for it, and encouraging that parent to be the advocate and have the confidence and trust themselves to ask those questions.
right. And I'm wondering if another source would be a child specialist. I think that sometimes there are very good therapists working with
Yes.
gastros, ENTs. I mean, you'd have to
Yep.
go there.
100%. And I always, I mean, my child life specialists they're the best. And I always tell parents, even if they're just going for an outpatient visit, and I have a child who's very sensitive and has a lot of environmental needs to help support them. I'm making that parent call and get that child life specialist in there, tell them what works. You're going into these tests, they're scary for some kids, most kids. So what can we do to desensitize that environment and make it feel normal and safe for them? Because again, at mealtime, everything around the mouth, the nose, the face, really, it impacts it.
Right, right. And I think if you can't find it through those venues, then look into private if you can at all.
Yes, I know, and 100%, if you can absolutely do it there. I mean, there are wonderful therapists out there that can do amazing things for your child and your family to desensitize that and or heighten the sensitivity to it. But it mealtime should be positive and for everyone. This is not just the child that you're treating.
Right.
It's such a socially normal thing to do. And parents often are like, I just want to be able to go out to dinner with my child and have it be a normal meal time. And I always say, like, you will. It's just not going to happen next week. Like, it takes time and patience. So having the parent understand that.
Right. It's a marathon, not a sprint. But also, I think it's important
Exactly.
to understand the type of therapist you're choosing because you, as an
Yes.
occupational therapist, are looking at different aspects of feeding than a feeding therapist slash speech therapist would. I'm putting feeding therapist,
100%.
but speech therapist, also nutritionist. Everybody
And
has
yeah.
a piece of the puzzle.
Uh-huh. And I often find that usually these children I'm getting referred to aren't like, I'm not the first therapist that they've ever worked with, or specialist or doctor. They've seen a multitude of staff members. And I always ask the parents, like, what's your child responded to? Should we maybe, now that they do have a little bit more foundational oral motor skills, let's tap into another speech pathologist because they're going to offer something more, and maybe it's worth digging into and giving that opportunity for your child.
Right. And I think early intervention is so, so valuable because the
So
longer
valuable.
they go on, the harder they are to change, right?
Yes, 100%. And again, I respect all of our pediatricians too, who are not even just offering early intervention, but looking early, and knowing what to look for and saying, something's not right with this feeding. Like, let's just figure it out now, or try to figure it out now. Or planting the seed for parents, because it, like you said, I mean, neuroplasticity is real, and it matters. And it's so much easier helping a parent with a 6-month-old than it is a 6-year-old. Not always, but it usually is a lot easier.
Right. It is so, so, so true. And also just bringing down the anxiety, removing the guilt.
Yes.
Pediatricians are good at that. We have to do more.
Yes.
That's one of our specialties. I want to let you end on a positive note, because I know you wanted to talk about strategies to encourage positive mealtime experiences. Hunger, I think you talked about already, but positive.
Yes. Hunger's the big one. I think balance is kind of the best way that I would summarize balance and patience. I get the phone call, like, I've tried this type of therapy, I've tried that, nothing's working. They're still like, I'm having all these oral motor issues. And it's just, okay, let's decompress. And I think having the parent be able to have me or whoever they're seeing as their sounding board, that layer needs to come off for the parent. Because if that layer of anxiety and guilt and pressure and just negativity isn't off of them, it's not going to come off the child. So we can't treat whatever sensory issues to the child if I'm not helping and supporting the family.
Right.
And so I always say, like, what's your biggest goal? How can we do this together? Right? They have to feel that support from you as the therapist, because that's what's going to translate to the child. So how can we set up mealtime for success? Baby goals, right? I like for parents and children to see results, and understanding that the result doesn't need to be going out to a fancy dinner with your entire family, but maybe it can be that a leaf of spinach is on your child's plate that day, and that's a win, and it will get there. Whatever the journey looks like, it will get there, and just setting up mealtime for success, and taking that pressure off.
Right. I want to
Letting go of that control is the big thing.
I'm so on the same page. I want to put in a plug for realistic expectations, because I find
Yes.
it very common that parents think a child's going to sit at a table like a little adult.
Yes.
And what I like to say is, expect your toddler to have one good meal, one bad meal, and one no meal, and the no meal will be dinner.
It is so true. As a parent, and I have to tell, I have a 3-year-old and an 18-month-old, and I've been treating the pediatric population for way longer than that. And it changes. I see things differently as a parent, and I hope it made me a much better therapist, because I'm able to empathize how just the parent role is so crucial, depending on wherever the child is. If it's a smaller, I don't want to say minor, but like, more manageable feeding sensory issue versus a much more complicated one, it's hard. And it's okay to say that it's hard, and it's okay to say that you need help. And I think a way to set it up and have that success is accepting help, and accepting that it's okay to get help. That's what we're here for.
Right. And it's okay to get help for yourself. A lot of
100%.
grown-ups have eating like hang-ups, issues.
Yeah, and like you said, you remember those shakes when you were a baby, like and just understanding every moment matters, and trying to kind of just take that control back. I find myself, even too, I'm a feeding therapist, I'm like, oh, just 2 more bites and then you can get up from there. I'm like, no, it's okay. Like, I always joke, like, what is that one extra bite doing? Absolutely nothing. Like, it's just causing stress.
Feel better. It
Yes.
makes you feel better.
Exactly.
So I think this has been amazing. I think you gave us a lot of good information, and it's really interesting to hear the occupational therapy / sensory perspective, because I don't think enough people hear that. And I think it's really important.
Yeah, and I think people hear sensory processing and sensory integration, but they don't understand what it means. They don't understand what you can offer in terms of helping.
Right, and how it would impact feeding.
And your feeding routines. Yeah.
Right. So I thank you so much for doing this with me. I'm going to have to go over all the other sensory issues in another talk. So
yes.
This took a long time, and we just scratched the surface of it. Really.
I know.
But
Have me back. I would love to come back. This was
Yes.
wonderful. Thank you for having me.
I really, really appreciate it. And thank you for being there for my patients.
Of course, and right back at you. Thank you.
Yeah, this was wonderful. I really appreciate it.
Great. Me too.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.